A patient of 30 years, he got the roadside accident and interior knee impact leading to the fracture of the PCL. The big fragment is over there. It's a type 3 PCL avulsion fracture. CT, there is again in sagittal section, it's a big chunk on the dorsal side, and the piece is placed from here to here, and this piece is also visible. If you see the position of the patient is in prone position. We put the image intensifier. We're going to mark it. See the image intensifier over here. This is a crease area. The natural crease, you can mark over the natural crease. This way, it's the joint. And then the posteromedial side. If you view, this is over here. And if you go for the lateral, we have marked this. There are different approaches for it. One is that the hockey shape in CN. You got a flap, long flap, and then you go through the medial head of the gastrocnemius and semimembranosus. And the second is a novel approach through the center between the two heads of the gastrocnemius, just split it. And the back of this one is you just come over the popliteal vessel, means popliteal artery. This is a mini open approach. You have to stay just distal to the skin crease of the knee joint. Either needed, you can extend it proximally. It's 4-5 centimeter in CN. The fracture is probably gonna be over here, and the vessel is going here. We'll go through the skin subcutaneous tissue, and then we will be over the medial head of the gastrocnemius. We'll split the gastrocnemius fascia in line with, and then split. Then the lateral half of the gastrocnemius medial head will retract the vessel and will go directly over the posterior capsule of the knee joint. The section scissor. So you will split it in longitudinal direction, this way. I'm just gonna put my finger there. So the vessel will go on that side. If you see, the fragment is there. This is the fragment. This is the fracture area. Now we're gonna open the capsule, L shape in CN. Be careful, you have the vessel on the other side. Elevate the capsule on the posterior side. Stitch it back. All the soft tissue has been removed. This is a crater. We'll reduce it and fix it with the screw. Try to reduce it with the flexion of the knee and pull off the fragment down with your, or pushing the fragment down with your finger. Soft tissue removal from the interposition area. We'll pass one wire under image intensifier. This wire is just to hold the fragment. Chemically reduce. We'll check under image intensifier, and then we're gonna put the definitive wire. This is the big chunk which was over here before. Now it's been comical position. This wire is on extreme edge. We're gonna target the wire over here. So this is the definitive wire, and we will leave it as such for the compression for the distal part. So this is the 55 screw, and we keep the second wire just for stability. It's well compressed now. See the fragment now. This is totally compressed. Well compressed in the crater and well reduced. You'll see under the image now. So fragment is totally been compressed and anatomically reduced. Let's remove the wires. Check it again. We have engaged the cortex with the 4 mm cannulated screw. This is the fragment. It's back into its crater, or it's been well reduced. This is PCL. This is full flexion, full extension. We'll put the brace and start the passive range of motion flexion in prone position. Size of the screw is optimal. It's just engaging the anterior cortex. So this is very safe approach. This is the capsule. So make sure you have to close the capsule. Watertight closure is required. So we have closed the capsule on the posterior aspect. That is very important to keep the knee watertight. We will close the epimysium and this subcutaneous, and then skin.
Okay.
Here is scar mark, almost 4 to 5 centimeter. Yeah, good. वापस interior draw negative, interior draw negative. If we compare in the other one, it's also compare.